Morning, everyone. Today I'll be talking about predicting the future risk of knee replacement surgery in patients with osteoarthritis. I'll start by providing some background to our study, and then I'll discuss how the model was developed and the results from the model, and I'll end by summarising some future work arising from this study. So we know that over 9% of Australians are affected by osteoarthritis, and that OA is the fourth most common reason for consultation in general practice. In the last 10 years, the rate and cost of total knee replacement has risen by 38% and 29% respectively. In 2016, approximately $2.1 billion was spent on the management of osteoarthritis in Australia. As the population continues to age and obesity rates increase, this is forecasted to reach $2.9 billion by 2030. So despite total knee replacement being a cost-effective surgery, approximately 12 to 20% of patients who undergo total knee replacement do not report improvements in pain and function. This slide here shows you the typical pathway for a patient with osteoarthritis. The general practitioner is often the first point of contact for the patient. They may then refer the patient on to an allied health specialist, and as the patient's osteoarthritis progresses, they may then go on to see an orthopedic surgeon and possibly undergo total knee replacement surgery. So general practitioners are the first point of contact, and they can play a critical role in helping prevent the progression to total knee replacement surgery by identifying early on those patients at risk of the surgery. By identifying these patients early, we then have the opportunity to implement and optimize first-line treatment strategies, such as exercise programs or weight loss management programs, and this may delay or even prevent the need for total knee replacement surgery in the future. So the purpose of this study was to develop a prediction model to predict total knee replacement surgery in 5 years for use in general practice in patients aged 45 years and over with osteoarthritis. The model was to be integrated into the general practice electronic health records, so it could be used at the point of care. I will now go on to speak about how the model was developed. So the main data source for this model was general practice electronic health records provided by NPS MedicineWise. These data were then linked with the Australian Orthopaedic Association National Joint Replacement Registry and the National Death Index, so that we could validate the accuracy of recording of total knee replacement, which was the outcome for our model, and the competing risk, which was death in our model. And we wanted to validate these fields prior to model development to make sure we were actually developing the model from accurate and complete data. I'll now summarise the main methods that we used to develop the model. So initially we determined the potential predictors, and this was done from a literature review as well as handing out surveys to experts in the field of osteoarthritis. Initially 32 predictors were identified, but unfortunately only 8 were available in the general practice record because only 8 of these predictors were routinely collected in general practice. These were age, the prescribing of osteoarthritis medication, BMI, count of chronic conditions, a recording of a mental health condition, previous contralateral total knee replacement, any past knee surgery other than total knee replacement, and geographic location of the patient. The second step involved cleaning the electronic health record data, which took approximately 9 months. As you can imagine, there's a lot of information in these records, but essentially the data is collected for clinical purposes and not research. So it's not in the format required for analysis and really required a lot of data cleaning. And step 3 was actually formatting the linked data even further so that it was ready for input into the model. The fourth step was the data quality assessment, as I mentioned before. And the results from this assessment indicated that we actually had to use the linked data to develop the model, as both the outcome and the competing risk, so total knee replacement and death, were not accurately recorded in the electronic health record. BMI was also poorly recorded in the health record with approximately 70% missing data. And this meant that we actually couldn't use this predictor in our model. Having to exclude such an important predictor in our model was actually really disappointing. And I guess what it says to us is that we need more accurate and complete recording of patient data in general practice electronic health records if we're going to continue to use these data to develop prediction models. In step 5, we created multiple imputation models to impute missing data. We created 27 imputed data sets. We then built the model in each of these imputed data sets, tested the model mathematical assumptions, and obtained measures of model performance using bootstrapping. This is a summary of the characteristics of our study cohort, which consisted of approximately 200,000 patients from close to 500 general practices across Australia. Approximately 8% of patients underwent total knee replacement surgery in our 5-year study period, and 7% died. The mean age was 67 years, and the remaining predictors have been summarised in that table there. In the interest of time, I won't read these out. So these are results from the final model. We fit a fine and grey competing risk model where death was treated as the competing risk. You can see here from the column that's labelled subdistribution hazards ratio that in fact there's a quadratic relationship between age and the outcome, total knee replacement. So for every 1 year increase in age, the rate of total knee replacement in subjects who are event-free increases until the patient is about 65 years, and then that rate decreases. The prescribing of osteoarthritis medication in the 12 months prior is associated with a 50% increase in the rate of total knee replacement in subjects who are event-free. For every 1 increase in chronic condition count, the rate of total knee replacement decreases by 13%. The rate of total knee replacement is 13% less for those with a mental health condition. The rate of total knee replacement is 2.63 times higher if the patient has undergone contralateral total knee replacement, and 2.5 times higher for other knee surgery. The interpretation of this model can be tricky. Here we've talked about the effect of the predictors on the rate of total knee replacement. But what does this actually mean in terms of risk or probability of total knee replacement, which is essentially what we're really interested in here. So we can view the model in its app form. And this is the link here. So just bear with me while I share this screen, please. So you can see here the results of the model are shown in an app sort of format. So if we, on the left-hand side, we have all the predictors, and if we set these all to no to start off with, you'll see on the right-hand side the estimated probability of total knee replacement in 5 years. So as we increase age closer to 65 years, you can see that probability increases. After 65 years, that probability starts to slowly drop off. If we then say the patient was on osteoarthritis medication, you can see that probability again increases. If the patient has one chronic condition, that probability decreases, and obviously as we increase chronic conditions, that probability decreases. You can see also that if the patient has a diagnosis of a mental health condition, the probability of knee replacement in 5 years decreases. If they've had a past contralateral knee replacement, that probability actually increases quite a bit. You can see it's jumped to 0.21 there. And if we say then now that they've actually also had previous knee surgery other than total knee replacement, you can see that probably jumps up even further. So this is one way to view the results of the model in an easy to interpret fashion. So I'll go back now to the slides. Okay, so now that we've seen the model, how does it perform? One way of measuring model performance is discrimination. And in the competing risk setting, discrimination quantifies the ability of a model to predict who will develop an event earlier and who will develop an event later or not at all. So you can see out here, our algorithm correctly predicts who will undergo total knee replacement earlier between 2 patients approximately 67% of the time. So that is, the algorithm correctly predicts that the riskier patient of the pair will undergo total knee replacement earlier 67% of the time. As a rule of thumb, a discrimination or C statistic of greater than 0.7 is considered good. So you can see here we're slightly under that level of good. And this was really not surprising, as we were unable to include BMI, which we suspect is an important predictor in the model because we didn't have enough complete data. And also we're restricted here by only being able to use variables or predictors that are routinely collected in general practice. Calibration is another method of measuring model performance, and it shows us how well the predicted risks agree with the observed risks. The green line there is the y=x line, which it shows perfect agreement. And you can see our model does pretty well with calibration. There's only a slight deviation, I guess you could say, for the top 2 deciles from that green line. So what does this mean and where do we go from here? So we've developed this model and internally validated it. We now need to externally validate it using another Australian electronic health record data set to see whether our model performance measures hold up. During this exercise, we're hoping that we'll also be able to update the model with any other predictors that may be now available in this new electronic health data set that we use. So perhaps an important predictor like health insurance may be available to us, or there may be some other predictors that are complete or accurate in this second data set that will help us improve the predictive performance of this model. Following this, we may then consider running the model in a totally different way by using a machine learning approach. And after that, we'll be developing a prediction model for non-response to total knee replacement using electronic health record data again. I'd like to thank my supervisors, Michelle Dowsey, Paddy Chondras and Joanne Mansky-Nankervis. Some references there, and thank you for listening.